Hello.
Yes,
So, sir, it's 3, 2, 1. Sir, you are live now. Or
thank you very much, and good evening to you all. This evening, we are going to talk on dapagliflozin bridging the gap in heart failure management with or without diabetes. Now, this is a little busy slide, but all it does is it defines what is heart failure. And this is a heart failure is a severe failure of heart to pump blood enough around the body, and the symptoms include breathlessness, fatigue, and swollen limbs. If you go into the technical details of it, it means that heart is not able to pump adequately, or even if it does adequately, it is at an increased filling pressures. So depending upon which side of the heart has got a higher filling pressure, you can say it is the left heart failure, right heart failure, or biventricular failure. Now, the problem with heart failure is that the quality of life is poor, with survival is almost truncated to the extent that 45 to 60% people die within 5 years. It is a very, very severe disease in the sense that the reality check says that 26 million people suffer from heart failure worldwide. And if you account for people who are undiagnosed cases, then the estimate is roughly around 37.7 million people, which is huge. The lifetime risk of developing heart failure is about 20% or thereabout. And this is the number one reason for hospitalization. More than 50% of people who are hospitalized heart failure, they they come back with heart failure within 6 months of discharge. So these are very concerning statistics. Now, if you look at the data from different studies as far as what is the relation of heart failure with and without diabetes, people with diabetes have significantly higher number of involvement in heart failure. So this is from Framingham data, where you find that if you look at diabetic men, the incidence is 7.6 per thousand, whereas if the men are non-diabetic, it is almost half of it, 3.5 per thousand. Similarly, for women, it is 11.4 versus 2.2. So it's a drastic difference. Look at the cardiovascular health study. Again, for men, it was 44.6 with diabetes versus 22.9. Similarly, for women, the incidence was large as compared to non-diabetic women, 32.5 versus 12.1. Heart and soul study was a large follow-up of about 4.1 years or thereabout. Again, the diabetes had 36.6 per thousand versus 7.9 per thousand for non-diabetic. And Nahan's study, again, is a very large follow-up, as much as Framingham study with a follow-up of about 19 years or thereabout. In men, it was 65.5%, whereas for non-diabetic, it was 36.9% as against diabetic men of 65.5%. So for diabetic women had 61.8% and non-diabetic women were 28.9%. Now look at the problems with kidney disease, and this is very quick check. 850 million people worldwide have some or the other sort of kidney disease, which is almost about 10%. 2.4 million deaths each year are caused because of chronic kidney disease. Diabetes and hypertension are very, very commonly associated, and these are the two reasons for CKD and accounts for almost about 75% of people. And 9 in 10 people with CKD don't know that they have it. So it is total ignorance and lack of awareness, which is another reason for major concern. Prevalence and manifestations of kidney disease in diabetic and non-diabetic population, if you look at this, all forms of kidney disease. So non-diabetic are much lesser as compared to diabetic. Albuminuria, impaired GFR, both, when you look at it, the number of non-diabetics will have much lesser incidence and prevalence. So this is prevalence, not incidence, that non-diabetics have lesser of prevalence as compared to diabetics. Now, in prevalence of CKD in diabetic is also equally bad. So in diabetic, when you look at CKD, 2.3% people will have CKD, whereas non-diabetic CKD will be 9.4%. So, and 10-year cumulative all-cause mortality is much larger, 8.6% versus 19.10 and 19.10% with diabetes. This is diabetes and heart failure are linked, and treatment should be too, because if you look at diabetes mellitus type 2, these are characterized by elevated sugar levels, and almost 2 to 4 times are likely to develop heart failure than someone without diabetes. But heart failure, a condition in which both heart fails to efficiently pump oxygenated blood through the body, also is a risk factor for diabetes. Both disorders are characterized by insulin resistance and high levels of inflammation. So 6-year CHF incidence per 1,000 people age-wise is, when you compare to non-diabetic patients, the ratio is 11.5 in less than 45 years, and as the age grows, there is a significant difference, which is for diabetic patient as compared to non-diabetic patient. So diabetes, heart failure, and renal dysfunction, this is a vicious circle. If you look at diabetes per se, which is the mother of all the diseases as far as heart failure and CKD is concerned, then it's a major risk factor for diabetic kidney disease. It is also a major risk factor for heart failure. And this intensifies both. When there is a heart failure, it worsens diabetes because of whatever reasons, because there is a neuroendocrine system which gets activated and worsens the sugar control. However, if there is a sugar which is bad, it worsens heart failure, and this is what is an Now, if you have a diabetic kidney disease, unfortunately, the treatment for kidney disease is bad for heart failure, and the treatment for heart failure is bad for kidney disease. So conventionally speaking, if you look at it, poor kidneys need more of water, and poor heart needs less of water. So when you give diuretics in a heart failure, the kidney functions deteriorate. When you give more of fluid intake for kidney disorder, heart failure worsens. And this is the reason why each of them intensifies the severity for each other, and they become cause and effect for each other's misery. Now, not only that, when there is a kidney disorder and heart failure, both lead to sodium retention, which worsens both the disorders. Now, this is something which is known as the vicious circle between type 2 diabetes and heart failure. If you look at this, insulin resistance is the central point in the development of diabetes. Now, this is responsible for insulin hypersecretion, and when there is a hypersecretion with progression in insulin secretion of the pancreas, hyperglycemia signifies the presence of diabetes mellitus, and then this hyperglycemia lands up with macrovascular complications, include epicardial coronary artery disease, cerebrovascular accident, aortic and peripheral artery disease. This goes and worsens. If you look at this, this is the presence of advanced glycation end products, which is responsible for adverse clinical outcomes in diabetes mellitus. This further causes an accumulation of reactive oxygen species, which in turns triggers inflammation, and advanced glycation end products also can lead to cardiac fibrosis, which causes myocardial stiffness and leads to HEF-PEF, heart failure with preserved ejection fraction. There is a development of heart failure, which causes activation of two systems. Now, these two systems will keep coming as a recurrent theme in this talk, which is activation of RAS and sympathetic activation, which is the sympathetic outflow tract activation in form of epinephrine and norepinephrine secretion. This leads to retention of sodium and water, and the sympathetic nervous system causes lipolysis. This lipolysis, when combined with typical Western diet and obesity, can lead to insulin resistance, and thereby completing this vicious circle, which further worsens the diabetes. Now, this is the pathophysiology of diabetes mellitus and heart failure. Largely speaking, diabetes leads to hyperglycemia, insulin resistance, and hyperinsulinemia. When it comes to inflammation, dyslipidemia, endothelial dysfunction, it leads to coronary artery disease, which eventually might lead to ischemic cardiomyopathy and heart failure in diabetes. However, there are other modes also: cardiomyocytes hypertrophy and LVH, activation of RAS, calcium handling, fatty acid utilization, formation of advanced glycated end products leads to fibrosis, autonomic dysfunction. This leads to diabetic cardiomyopathy, again leading into heart failure in diabetes mellitus. Now, these are the thing that how can we help as far as diabetes is concerned. What are the therapeutic options? So these are the ones which are commonly used current pharmacological therapies to lower hyperglycemia: biogonide, sulfonylurea, TZDs, GLP-1 receptor agonists, DPP-4 inhibitors, SGLT2, and insulin. So these are for all diabetes mellitus, and they act on different levels: liver, pancreas, kidneys, adipose tissues, and skeletal muscle. And these have variable response for heart failure. Now, these are the potential pathways that could be targeted to modulate specific pathophysiological mechanisms that contribute to diabetes-associated heart failure. So altered myocardial substrate metabolism, mitochondrial bioenergetics, oxidative stress, lipotoxicity, inflammation, endothelial reticulum stress, insulin signaling, beta-2 adrenergic. Then there is something known as a GRK2 signaling, which is G protein coupled receptor kinase 2 signaling. There are several things which have been discovered. Most of them have some relevance or the other as far as association is concerned, but many a times we don't know their clinical implications. But renin-angiotensin-aldosterone signaling mechanism is very, very important. Autophagy and advanced glycated end products are to be mentioned, no doubt. Now, this is an ominous octet which was propounded by DeFronzo, in which there are how different anti-diabetics act on different available therapies at which level. So if you look at this DPP-4 inhibitors, these act on decrease incretin effect. So both DPP-4 and GLP-1 receptor agonists, both of them are incretin-dependent anti-diabetics. So these are the ones which increase lipolysis. When it comes to SGLT2 inhibitors, this is the point of discussion today. There is an increased glucose reabsorption. TZD, these are the glitazones which have gone out of repute. There is a decreased glucose uptake, neurotransmitter dysfunction. Metformin is working through the hepatic glycogen production. DPP-4 and GLP-1s also do the increased glucagon secretion. Insulin and sulfonylureas act by affecting the insulin secretion from the beta cells. Now, these are the effects of diabetes mellitus treatment on risk of heart failure. So when it comes to DPP-4, there is no risk of heart failure except for one which has worsened. I'll talk about that molecule too. Number two is there is a SGLT2, which has shown to be most promising for heart failure, improves cardiovascular risk factors, weight reduction, reduction in systolic blood pressure and improved lipid profile, reduction in cardiovascular mortality and hospitalization from heart failure, increased glucose reabsorption. This is how it works. Then there is a decreased glucose uptake with glitazones, and unfortunately this has become a reason for their not being used, because they lead to fluid retention and weight gain as a side effect, and precludes its use in NYHA class 3 and 4. So be cautious whenever you have to use glitazones. Most of the times, as a cardiologist, I would prefer not to use them at any given point of time. Metformin has been the gold standard of therapy as a first line of therapy, shown to be plus minus and reduce some kind of mortality in heart failure, reduces cardiac hypertrophy by activated protein kinase mediated and repression of mTOR. mTOR is mechanistic target of rapamycin, and this was a regulation of cell survival, metabolism, growth, and protein synthesis in response to upstream signaling, which metformin effects. Now, GLP-1 receptor agonists are very interesting because it does not increase risk of heart failure, but there is a modest improvement in ejection fraction of heart failure patients, though it does not improve survival to the extent of SGLT2, but they have some bit of protection against the atherosclerotic coronary artery disease, or the atherosclerotic CVD, ASCVD. Then comes insulin, and insulin again has been a matter of great ups and downs. So there is no definite CV outcome trials examining sulfonylurea in heart failure, and it has been something which is again as good or as bad as not to be given if you can avoid, unless there is a compelling indication to get the HbA1c down. Now, these are the guidelines and recommendations for oral antidiabetics and heart failure. So first line therapy is metformin, which along with comprehensive lifestyle. I mean, this is a very, very debatable issue whether we should really have metformin as the first line of therapy, especially if there is a established atherosclerotic cardiovascular disease, or there is a established CKD, or there is an established heart failure which predominates. But if you look at this busy chart, the sum and substance of this busy chart is that if atherosclerotic cardiovascular disease predominates, GLP-1 receptor agonists or SGLT2 are preferred. Which is the one which should be given when? It's a very, very debatable issue, but people who would want to be purist for prescription, then if you want to save the pumps, give SGLT2 inhibitors. If you want to save the pipes, that is the coronary arteries, then give GLP-1 receptor agonists, though the overlap can be very, very significant. Now, if heart failure or CKD predominates, then SGLT2 is preferred, like the way that I said that if you want to save the pump or the kidneys, then SGLT2 inhibitors are preferred. And if there is a compelling need to minimize hypoglycemia, then the ones which have very little effect as far as hypoglycemia are concerned are DPP-4 inhibitors, GLP-1 receptor agonists, SGLT2 inhibitors, and TZDs. These are preferred. Now, there is yet another condition where there is a need to minimize weight gain or promote weight loss. And then again, GLP-1 receptor agonists and SGLT2 inhibitors are preferred. The American Diabetic Association and European Association of Study of Diabetes has come up with updates which were about 2 years back, and they said that if atherosclerotic cardiovascular disease predominates, GLP-1 receptor agonist or SGLT2 should be given. However, if there is a heart failure or CKD which predominates, then SGLT2 inhibitors are preferred. So this is again cutting too close. This is the impact of glucose lowering medication on cardiovascular endpoints in cardiovascular outcome trials and heart failure hospitalization. Again, this has been picked up from American Heart Association 2019. If you look at the primary outcomes, then GLP-1 receptor agonist, if you look at semaglutide and liraglutide, these are the one where there is a primary outcome advantage in form of cardiovascular death, MI, and stroke. When it comes to sexagliptin, then this is something where there is increased risk of heart failure. So when I was saying that DPP-4 inhibitors have to be used with caution, at least this caution should be exercised all the time, that if at all you have to give something, then give sitagliptin is available in our country, and we can give that very cautiously, though, along with other antidiabetics, but avoid giving sexagliptin because it increases the risk of heart failure. Now, SGLT2 inhibitors, whether you talk about dapagliflozin or whether you talk of canagliflozin, they reduce the risk of heart failure hospitalization and decrease the risk of heart failure hospitalization both. Now, this is an association of glycemic medications with risk of cardiovascular events and heart failure hospitalization. When it comes to, this is a forest plot, and how you analyze this forest plot is try to look at where the dot lies. If it is on the right side of unity versus the left side of unity, this favors usage of drug. This does not favor if it is on the right side. And number two is you see the length of this bar, which is the confidence interval. If it is crossing the bar of If this bar crosses the line of unity, that means it is significant. It is not as statistically significant, or that means the p-values are lesser than 0.04. So the confidence interval bar should not cross the line of unity. And if you look at canagliflozin and empagliflozin, both of them have the bar, whether it is for major adverse cardiovascular events or heart failure hospitalization, both of them have got a hazard ratio which is clearly on the left side of line of unity. Not only that, we have some evidence that semaglutide also has major adverse events contained. But when it comes to heart failure hospitalization, this doesn't help. And that is the reason why now, if you're talking about GLP-1 receptor agonists, then when it comes to major adverse cardiovascular, they can be given. But when it comes to heart failure hospitalization, then only SGLT2 inhibitors are the ones which are of any utility. Now, this again is clinical consideration of SGLT2 inhibitors from American Diabetic Association and European Association of Study of Diabetes and American Heart Association. So this is the one with EASD and American Diabetic Association. This is purely from diabetologists. This is purely from the heart failure specialists. So we'll talk about what the diabetologists say, that for patients with or without established atherosclerotic cardiovascular disease, but with heart failure with reduced ejection fraction or CKD, or if your urinary albumin creatinine ratio is more than 30, especially if it is more than 300, the level of evidence for benefit is greatest for SGLT2 inhibitors. So this is a very strong statement to be made. And SGLT2 inhibitors are recommended in patients with type 2 diabetes and heart failure, particularly those with heart failure with reduced ejection fraction, to reduce heart hospitalization due to heart failure, major adverse cardiovascular events, and cardiovascular death. SGLT2 inhibitors are recommended to prevent the progression of CKD, hospitalization due to heart failure, major adverse cardiovascular events, and cardiovascular death in patients with type 2 diabetes with CKD. And what do the heart failure specialists say? Heart failure specialists say that SGLT2 inhibitors, first class of glucose lowering agent, demonstrated to reduce risk of heart failure hospitalization in patients with diabetes. So this is established. Combined with significant reduction in cardiovascular and all-cause mortalities seen with SGLT2 inhibitor, it is reasonable to consider SGLT2 inhibitor use as a part of prevention strategy in patients with diabetes at high risk of heart failure. So this is also established, that for people who have got high risk of developing heart failure, SGLT2 inhibitors can be given for diabetes control. Now, another thing which is very interesting is SGLT2 inhibitors are also good for glucose lowering medication choice in patients with established heart failure and diabetes. And this class appears most promising for treatment in established heart failure in patients even without diabetes. So this is the strongest statement which has been made by the American Association, Heart Association, that even whether it is heart failure with or without diabetes, SGLT2 inhibitors have become a real very strong pillar in the armamentarium of so many others available. Now, SGLT2 is the bridging the missing link of cardio-renal syndrome with or without diabetes. Now, we are talking about heart failure and cardio-renal syndrome. Cardio-renal syndrome is a very tricky thing to handle. And when it comes to heart failure with reduced ejection fraction, we know that 5-year mortality rates are grossly bad. And the proportion of patients receiving guideline recommended doses of RAS inhibitors and beta blockers is very low, as much as 22% and 12% respectively. Now, there is yet another Achilles heel, that is heart failure with preserved ejection fraction. And the treatment is reliant on management of comorbidities and symptoms. Unfortunately, there is sketchy data that SGLT2 inhibitors can be of benefit with heart failure with preserved ejection fraction. But that is the only thing available probably at this point of time. Then there is a cardio-renal syndrome where the RAS inhibitors and diuretics can be beneficial, but also can serve as a double-edged sword and can worsen renal functions. Now, this is the cardio-renal efficacy of new anti-hyperglycemic drugs in primary and secondary prevention. When it comes to primary prevention, that means diabetes, plus multiple risk factors. When it comes to events like major adverse cardiac vascular events, then nothing is very dramatic. For heart failure, SGLT2 is better. And for diabetic kidney disease, SGLT2 is better. So when it comes to primary prevention, then nothing works for major adverse cardiovascular. However, if you want to do a secondary prevention, then MACE is reduced by SGLT2 inhibitors and GLP-1 receptor agonist. Again, the established heart failure and diabetic kidney diseases, SGLT2 inhibitors are better. Now let's see a few case examples which are day-to-day happening in anybody who's practicing diabetes or CKD or heart failure or coronary artery disease for that matter. So here is an example of a 68 years old woman at a high risk for heart failure with diabetes, hypertension, dyslipidemia and coronary artery disease. Serum creatinine is 1.1 and EGFR is 55 ml per minute per meter square. Now, what are the choices for glucose lowering medication? Well, metformin is the first line of therapy, which I'm not too sure for how long this will remain the first line of therapy. But if you want to add on something else, then SGLT2 inhibitors may decrease risk of cardiovascular events and heart failure hospitalization, and GLP-1 receptor agonists will decrease risk of cardiovascular events. So both have figures to defend their presence here, but for defense of heart failure, then SGLT2 is better. Which are the ones which should not be given? Glitazons may be not given because of increased risk of heart failure. DPP4 inhibitors, sulfonylurea, insulin. They should be considered only if unable to achieve adequate glycemic control with alternative option. Now, and again, run-of-the-mill 78 years old man with diabetes, recently diagnosed case of stage C heart failure with reduced ejection fraction caused by non-ischemic cardiomyopathy, which is 30% ejection fraction. Serum creatinine is 1 and EGFR is 77. What do you do? Metformin, SGLT2 inhibitors, clearly so. The contraindications are almost the same, except that sulfonylurea and insulin should be considered only if there is a compelling indication to reduce glycemic control with alternative options. What about GLP-1 receptor agonists? If you want to give something, then avoid GLP-1 receptor agonists if there is a history of recent heart failure with decompensation. Third garden variety of case which we see most often than not is 59 years old man with diabetes and recently diagnosed stage C HFpEF. This is heart failure with preserved ejection fraction. Now, like I said, that for preserved ejection fraction, there is only one thing which has been proven to be of some benefit, and that is empagliflozin. That is SGLT2 inhibitor, and all of us are looking forward to many more trials of SGLT2 because that seems to be the most promising drug for HFpEF. Again, avoid DPP4 inhibitors, avoid glitazons, and if there is a compelling reason, then you can add insulin or sulfonylureas. Last is a very interesting case, 72 years old woman with diabetes, stage C of heart failure with reduced ejection fraction 35%, serum creatinine 2, EGFR 25. Now what do? Do you give SGLT2 inhibitors? Well, as of now, the current recommendations are that do not give lesser than 30. Reason being that trials are being done with SGLT2 inhibitors with EGFR as low as 20, but for now should not use if EGFR less than 30, and the next choice is go into insulin. So these are recommended as potential management for heart failure with or without diabetes mellitus. Now these are the recommendations from American Diabetic Association and European Association for the study of diabetes and American Heart Association, of course, that the first OAD class to reduce cardiovascular mortality and heart failure risk, the only class with cardiorenal benefits with or without diabetes, And the only OAD class recommended by the latest guidelines is SGLT2 inhibitors, which bridges the gap of heart failure management with or without diabetes. Now coming to kidney and glucose hemostasis. Now, kidney is involved in regulation of glucose homeostasis via three different mechanisms. One is release of glucose into the circulation via gluconeogenesis. Second is uptake of glucose from its circulation to satisfy its energy needs. And third is reabsorption of glucose into the circulation from glomerular filtration to conserve glucose. Now, if you look at this, the filtered glucose load is about 180 grams per day. The first SGLT2 inhibitors, the SGLT1 and SGLT2 inhibitor, both, was discovered way back in 1835, and it was called as a fluorosin. Now, this fluorosin is a compound which was discovered in the bark of apple tree and pear tree and cherry tree. It is found in that kind of class, and this was the first SGLT2 inhibitor, which was non-selective. It was SGLT1 and SGLT2. Now, when it comes to SGLT2 inhibitors, the effect is at multiple sites in a diabetic kidney. If you look at this, it is a novel insulin-dependent mechanism on reducing renal tubular glucose reabsorption, producing a reduction in blood glucose without stimulating the insulin release. This is one of the biggest advantages. Now, SGLT2 inhibitors enhance natriuresis, cause intravascular volume contraction, and alter intrarenal hemodynamics, which are likely to contribute to beneficial effects on blood pressure, body weight, and albuminuria. And this is an effect which is beyond the control of sugar itself. So these are pleiotropic effects and have translated into reduction in cardiovascular events and preservation of kidney functions in large cardiovascular outcome trials. Now, if you look at this, there is a proximal tubular cell. Here there is a sodium potassium ATPase activity, and there is GLUT2. This is glucose transporter in beta cells in pancreatic cell, and this is something which is very beneficial because it leads to clinical advantages of reduced plasma glucose, reduced body weight, reduce blood pressure, reduce plasma uric acid, and reduce glomerular hyperfiltration. And this leads to glycosuria and increased natriuresis. So both of them are very advantageous, except that with increased glycosuria, there is a high chance of perennial candida infection. Though UTI was a major concern, it's no more an issue, but you have to educate the patient on the perennial hygiene. So this is what SGLT2 inhibitors do for cardiac and nephroprotection. It is glycosuria plus natriuresis. And this combination is probably one of the best combinations to happen, because not only that, it reduces the cardiac afterload and preload both. It increases myocardial oxygen supply. It increases systolic and diastolic function. It reduces major adverse cardiovascular events and reduces the risk of heart failure. And as far as nephroprotection is concerned, then there is a decrease in intraglomerular pressure, in decrease in blood pressure, and decrease in progression to CKD. And this is how it works on different mechanisms, whether it reduces atherosclerosis, whether it increases cardiac contractility, whether it reduces inflammation and fibrosis. There's several mechanisms which are very complex to understand, but this is what the nut, sum and substance is in shell, what is available to us as far as clinical benefit from SGLT2 inhibitors is concerned. Now, what does SGLT2 inhibitors do? How do they do nephro and cardiac protection? It reduces glucose toxicity, it reduces plasma volume, increases hematocrit and hemoglobin, decreases systolic blood pressure, decreases arterial stiffness, improves cardiac fuel energetics, increases weight loss, decreases adiposity, and decreases inflammation. This is again at the risk of repetition. I may just be saying, but this is very important to carry it back home, that it is the natriuresis and glycosuria which are the beneficial effect for both heart and kidneys, and they reduce oxidative stress, decreases fibrosis, decreases local inflammation, decreases tubular senescence, and decreases glomerular damage. Uh, so mechanistically speaking, the rationale for investigating SGLT2 inhibitors in heart failure was seen beyond diabetes, and this was in patients without diabetes. So when you talk about without diabetes, then there is a mechanistic effect of SGLT2 inhibitors seen in patients with and without diabetes. Cardiovascular benefits in SGLT2 inhibitors are largely independent of glucose levels. Diabetes and heart failure have similar pathophysiological features like endothelial dysfunction, insulin resistance. And when you look at the mechanistic effects, then there is a diuretic effect and a metabolic effect, which leads to natriuresis, glycosuria, increased glucagon, and increased ketone bodies. So the journey of SGLT2 inhibitors started way back in 1835, where the French scientists isolated fluorescein in an apple bark, and then it continued to grow with SGLT2 inhibitors for diabetes were introduced in 2013 with an advantage proven over cardiovascular outcomes in 2008. EMPA-REG was the first trial with empagliflozin, and then CANVAS followed quickly with canagliflozin, and declared TIMI 58 was dapagliflozin, and last in the latest in heart failure is DAPA, which is the largest heart failure trial. Now, hospitalization due to heart failure reduces significantly for primary prevention population with multiple risk factors with DAPA. Secondary prevention reduces with not only DAPA but reduces with CANA and EMPA as far as heart failure is concerned, with reduction in MACE seen in CANA and cardiovascular deaths being better in empagliflozin. Now, this is the only SGLT2 with cardiovascular outcome trials with the majority of primary prevention patient population. In this, if you look at this with or without diabetes, the advantages were very significant because this was the only trial which had the largest number of patients without diabetes also. So the first and only FDA-approved SGLT2 for patients with heart failure with reduced ejection fraction with and without diabetes. No other SGLT2 indicated to reduce cardiovascular death in patients with heart failure with reduced ejection fraction with and without diabetes. So this is how the dapagliflozin offers a novel pathway that complements current therapies. This may be again a repetition of the same, so I'm not going into the details of that, but there is to give you a in nutshell, what this slide says is that there is a down regulation of sympathetic activity, there is a reduction in preload and afterload, and there is an improved survival in heart failure with reduction. So these are the approved indication and dose details. So when it comes to diabetes and heart failure, the approved indication for diabetes is that as an adjunct to diet and exercise to improve glycemic control in patients with type 2 diabetes, to reduce the risk of hospitalization for heart failure in adults with type 2 diabetes mellitus and established cardiovascular disease or multiple cardiovascular risk factors. When it comes to heart failure, then it is indicated to reduce the risk of cardiovascular death and hospitalization for heart failure in adults with heart failure NYHA class 2 to 4 with reduced ejection fraction. As far as administration is concerned, when it comes to diabetes, it is recommended that you start with 5 milligrams once daily, taken in the morning with or without food. And in patients tolerating dapagliflozin 5 milligrams once daily who require additional glycemic control, the dose can be increased to 10 milligrams once a day. To reduce the risk of hospitalization for heart failure in patients with type 2 diabetes and established cardiovascular disease or multiple cardiovascular risk factors, the recommended dose of dapagliflozin is 10 milligrams orally once a day. When it comes to heart failure, the recommended dose of dapagliflozin is 10 milligrams orally once a day. And most of the times, this is very, very, very well tolerated. When it comes to major adverse cardiovascular events, heart failure, and diabetic kidney disease, dapagliflozin is for primary and secondary, it is neutral. However, for heart failure, it reduces hospitalization and prevention of primary and secondary both, and diabetic kidney disease again, from primary and secondary diabetic kidney disease prevention to treatment, both dapagliflozin figures beautifully well. Now, this is the sum and substance of DAPA-HF trial. I'm not going into the details of the design of the study, but it was a large study with 4,744 patients with ejection fraction less than 40%. And the primary endpoint was composite worsening of heart failure, hospitalization on an urgent visit resulting in intravenous therapy, or cardiovascular death. These were the primary things. So when it comes to primary outcomes, there was a distinct advantage of 26%. When it comes to hospitalization for heart failure, advantage was 30%, very significant. Death from cardiovascular causes, advantage was 18%, and death for any other cause, this was 17% advantage. So among patients with heart failure and reduced ejection fraction, the risk of worsening heart failure or death from cardiovascular causes was lower amongst those who received dapagliflozin than among those who received placebo, regardless of the presence or absence of diabetes. So DAPA helped save lives by significantly reducing cardiovascular death or hospitalization for heart failure. Now, when it comes to DAPA-CKD trial, this was again to find out what the primary endpoints were. And the primary endpoints here were composite outcomes of sustained more than 50% eGFR decline, or end-stage kidney disease, renal or cardiovascular death, and secondary outcomes in hierarchical order were composite outcomes sustained more than 50% eGFR decline, end-stage kidney disease or renal death, cardiovascular death or hospitalization for heart failure, and all-cause mortality. Now let's look at the outcomes. Significantly better when it came to primary composite outcomes, significantly better, 39% advantage, which is so gross. Then it came to renal specific composite outcome, advantage was even better, 44%. When it comes to cardiovascular death from cardiovascular causes of hospitalization, again, dramatic, 29%, and death from any other cause was 41% advantage, 31% advantage. So this is among patients with chronic kidney disease, regardless of the presence or absence of diabetes, the risk of composite or a sustained decline in the estimated GFR of at least 50% end-stage kidney disease or death from renal or cardiovascular cause was significantly lower with DAPA than with placebo. What about albumin lowering effect of DAPA? This was changes in urinary albumin creatinine ratio induced by placebo, DAPA or dapagliflozin and sexagliptin at 24 weeks. So this was the placebo group, where at start it was 0.34, it worsened. When it came to dapagliflozin, there was a distinct advantage, and when you gave DAPA with sexagliptin, it was even better. So dapagliflozin with or without sexagliptin given in addition to ACE inhibitors or ARB treatment is potentially attractive option to slow the progression of kidney disease in patients with type 2 diabetes and moderate to severe chronic kidney disease. This is something very interesting, that initially in this derived study, there was an age mean change from baseline eGFR. So the findings in this study was that when you gave DAPA, there was a fall of eGFR because of perfusion issues, but over a period of time, this improved. And this finding of this study support that the positive benefit of risk profile of DAPA for treatment of patients with type 2 diabetes, and this was done for CKD 3A patients. So if you look at this, at the end of 27 weeks, there was a positivity. However, till before that, there was a little bit of a negativity. So this is over a period of time. When you control your heart failure, your eGFR will start improving. So eGFR is a function of improvement of heart failure, which takes time. This is renoprotective effects of dapagliflozin in diabetes. Regardless of whatever, there is a fall of ejection fraction measured kind of a GFR, which is this trial showed that it reduces MGFR beyond glucose control on top of standard of care, including RAS blockade and metformin treated diabetes without overt nephropathy. Again, this is Emperor reduced and DAPA-CKD, sum and substance of both of them combined. This is the diabetes mellitus patient, where there's an SGLT2 inhibitor when you give. Without diabetes mellitus, where do you give? In heart failure and EGFR more than 25 or albuminuria more than 200. And this is benefits beyond glycemic control, which you establish here. However, when it has come to only diabetes, then it helps in improving glycemic control. So Emperor reduced and DAPA-CKD clinical trials showed that SGLT2 inhibitors reduced hospitalization for heart failure and the occurrence of hard kidney endpoints in patients with or without diabetes, demonstrating that organ protection is due to factors beyond glucose lowering, and therefore comorbidity inherent in the cardiorenal syndrome is alleviated with the use of SGLT2 inhibitors. So the future is bright, and dapagliflozin does what really you want any drug to do. It improves survival. It reduces hospitalization. So symptoms, survival, and hospitalization reduction, these are things which improves the quality of life, quantity of life, and it reduces the pressure on the healthcare workers and the hospital resources. So there have been more than 80 trials ongoing beyond glycemic controls. So we are looking at dapagliflozin preserved ejection fraction trial. I'm very keenly looking forward for this. Dapagliflozin heart failure readmission. Dapagliflozin effect in cardiovascular events in acute heart failure. This has been something which has been always crossing my mind, that if it works in so well in chronic heart failure, why should it not work in acute heart failure? So this is expected to be available in a few years from now. Head-to-head comparison with empagliflozin and dapagliflozin. I'm not too sure what is going to be the outcome of this, because this is a very, very provocative kind of a study where what is going to be where, I'm not too sure, because to me, as all SGLT2 inhibitors have some kind of overlaps, except for some minor changes. Then dapagliflozin on nighttime blood pressure in type 2 diabetes. Nighttime blood pressure should dip. You must have dippers. Non-dippers are bad. If they don't drop your blood pressure at night, it is bad. So dapagliflozin is being tried on that. Dapagliflozin evaluation to treatment improve the lives of patients with preserved ejection fraction. Again, I'm keenly looking forward, because preserved ejection fraction is a great big Achilles heel for all cardiologists. Dapagliflozin in diabetic patients with decompensated heart failure. Again, this is going to be a positive study. I'm very sure about it. Efficacy and study the safety of dapagliflozin in acute heart failure. Dapagliflozin in respiratory failure, I'm not too sure what is going to be the outcome. Dapagliflozin effect on symptoms and biomarkers. Again, this is very we are looking forward to that more. And dapagliflozin on hypotensive heart failure patients after sacubitril valsartan therapy, and there are many more to come. So this is SGLT2 inhibitor class recommended by reputed bodies and preferred guidelines, whether it is the American Diabetic Association, ADA, ESID, ECC, in the management of diabetes with atherosclerotic cardiovascular disease, heart failure, or CKD, for reducing hypoglycemia and weight gain. More than 350 completed trials and 80 ongoing trials have proved the role of DAPA in glycemic control and beyond. DAPA-HF has shown survival benefit in heart failure with or without diabetes. It is the only FDA-approved SGLT2 for patients with heart failure with reduced ejection fraction with or without diabetes. No other SGLT2 indicated to reduce cardiovascular death in patients with heart failure with reduced ejection fraction with or without diabetes. And the future is bright. A much-needed molecule bringing the gap of heart, kidney, and blood glucose. Thank you very much for a patient listening. I'll be happy to take any questions in case there are any.
Hello.
Yes, please.
Sir, I think there are no questions. So, sir, can we wait for another 1 to 2 minutes if any question comes?
Sure, sure, sure. I think it was, I
Yes.
enjoyed the talk at least. I enjoyed preparing for it and I enjoyed the talk. And if there are no more questions, I think we'll call it a day. Shall we?
Yes, sir. Sir, I think there are no questions. So, sir, with your permission, can we conclude the session?
Sure, please. Go ahead.
Okay, sir. On behalf of the organizer, we would like to thank you for your insightful and educative talk. Thank you so much for your time, sir. So, sir, now I'm ending the meeting.
God
Thank
bless.
you. Thank
Thank
you.
you. Thank you.